This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Trey Bateman from Atrium Health, Wake Forest Baptist in Winston-Salem, North Carolina. Today, I have the pleasure of interviewing Simon Ducharme and Tristin Best from McGill University. Tristin is the lead author, and Simon is the senior author on a paper published online in Neurology on December 10th titled Association of Changes in Cerebral and Hypothalamic Structure with Sleep Dysfunction in Patients with Genetic Frontotemporal Dementia. In this paper, Simon and Tristin examined associations with sleep disturbances and neuroanatomic differences in patients with frontotemporal dementia who are carriers and non-carriers of key genetic mutations associated with FTD. Tristin and Simon, thanks for joining me today.
Thanks for having us. Thank you for the invitation, Trey. Happy to be here.
Anyone treating patients with dementias recognizes how common and distressing sleep problems can be for both patients and caregivers. Your paper looks at both the presence of sleep problems and associated neuroanatomic differences in carriers compared to non-carriers of the three most common genetic mutations responsible for frontotemporal dementia. You found that carriers of all three pathogenic variants had more sleep problems across the lifespan, but those with the MAPT gene mutation actually showed sleep changes before they developed clear symptoms of frontotemporal dementia. Before jumping into the details of the study, can you give us a quick overview of these three most common genetic causes and why thinking about genetics in frontotemporal dementia is particularly important?
Well, as you know, frontotemporal dementia can present in different ways. We have the behavioral variant, we have the primary progressive aphasias, but it's very important to recognize that about a third of patients with frontotemporal dementia are carriers of a pathogenic genetic mutation. So it's much more common than what we see, for example, in Alzheimer's disease, where the true genetic forms are extremely rare. While FTD is a relatively rare disease, within that population, genetic mutations are very common. So there's several mutations that can cause the disease, but there's a big tree that explain most of the genetic cases. So the first one is a repeat expansion disease in an area we call C9orf72, so on chromosome 9. So when you have too many repeats of that particular sequence, you can get FTD, behavioral variant PPA, and also it might be known to some other neurologists as a cause of ALS. So that's the most common genetic variant. And then you have mutations in the progranulin gene, which is causing a TDP-43 disease, and mutations in the MAPT gene, which is causing a tauopathy. So when we see patients with particularly behavioral FTD, practice is evolving more and more toward genetically testing all the patients. So obviously, if you have a family history of FTD, ALS, early onset dementia, the odds of finding mutations are much higher. But even in patients who seem to have sporadic variant with no family history, you do find some expansion in C9orf, even some mutation in progranulin in maybe 5 to 7% of cases. So it's really an important component of the disease that requires to be tested in most patients.
This is one of the really important reasons for figuring out, does this person really have frontotemporal dementia? Because the genetic implications are so much higher than with the Alzheimer's disease or Lewy body disease presentations. Now that we have a little background about the genetic associations in FTD, I want to move into talking a bit about the study. So you found that carriers of all three pathogenic variants had more sleep problems across the lifespan, but those with the MAPT gene mutation in particular actually showed sleep changes before they developed clear symptoms of frontotemporal dementia. Can you expand on this a little bit and tell us what the main findings in this study were when it came to sleep abnormalities and genetic status in patients with FTD?
What we found is that there's this differing evolution across the adult lifespan in these patients with these pathogenic variants, where we're observing this increasing presence and severity of sleep dysfunction across the adult lifespan. And this is regardless of the type of pathogenic variant. And like you'd said, with the MAPT variant, this sleep dysfunction appeared to be more pronounced. And when we looked at sleep dysfunction in only the symptomatic participants, we found that sleep dysfunction was relatively ubiquitous. It was really common throughout. But interestingly, in the pre-symptomatic carriers, so that's, prior to the onset of any symptoms that we typically associate with frontotemporal dementia, language problems, or behavioral or personality changes. We really see these sleep problems only in those with MAPT mutations. And this suggests that sleep dysfunction might be a more salient behavior symptom in MAPT mutation carriers.
You didn't just find that there were sleep problems there, but you found that there were neuroanatomic changes associated with those sleep problems as well, right? Those changes differed between the genes. So can you tell us a bit about those differences and why they might be important to consider? Do those differences hint at any potential treatment implications for sleep problems in this group of patients?
Yeah, of course. So in this study, we were particularly interested in alterations in the hypothalamus. And this is because the hypothalamus contains a number of nuclei that are critical to the regulation of sleep and wakefulness. And so for this study, the ones we're particularly interested in were the suprachiasmatic nucleus, which serves as the brain circadian pacemaker, the lateral hypothalamic area, which contains cell bodies of neurons containing melanin concentrating hormone, and as well as the wake promoting orexin neurons. And finally, the ventrolateral preoptic nucleus, which plays an important role in the maintenance of sleep and regulating sleep-wake cycles. So when we looked at the integrity of the hypothalamic structures in these individuals with the pathogenic variants, again, what we found is this differing evolution of hypothalamic subunit atrophy kind of across the lifespan, with MAPT carriers, again, showing the most consistent and the most severe changes in these structures, particularly in regions containing sleep-relevant nuclei. We also looked at the associations between brain structure and our measures of sleep dysfunction. And what we found are notable associations between the volumes of hypothalamic subunits containing the suprachiasmatic nucleus only in the MAPT carriers, and associations between changes in sleep dysfunction and hypothalamic volume in regions containing the lateral hypothalamic area. And this is particularly in MAPT carriers, but also in C9 expansion carriers as well. So we also looked at the associations between sleep dysfunction and cortical thinning. So this is a measure of brain atrophy. Interestingly, we found alterations only in GRN and C9 carriers, but not in individuals with MAPT mutations. So all of this taken together, what this might suggest is that these changes we're seeing in MAPT carriers in their sleep dysfunction may be driven by these changes in hypothalamic structures, and most notably the lateral hypothalamic area. And to get to your second question, what these findings may point to is the role of orexigenic neurons' sleep symptoms in genetic FTD. So previous work has found that there's reduced orexin levels in plasma and CSF associated with sleep problems in sporadic FTD. And orexin itself has been a neuropeptide of interest regarding sleep and FTD in general. And this may serve as a potential target for pharmacological interventions in FTD-related mutation carriers.
One of the things that I thought about seeing that in patients with Alzheimer's disease, I find myself using the orexin antagonists fairly frequently. What might this tell us, at least in the MAPT folks, about that? Like, is there a reason to think that we shouldn't be using those if we've already got loss of those orexin neurons, or what does it make you think?
First thing is to highlight that in those diseases, like had been shown in Alzheimer's disease, those pathologies go beyond the typical behavioral language symptoms. They involve some body homeostasis aspects, including sleep biorhythms. And when we try to treat pharmacologically behavioral symptoms of FTD, a lot of it is off-label prescription. We have a few studies, but if we talk about sleep dysregulation, we really have to go with good biological reasoning and systematic trial and error. So for me, what I take from this is that there's probably some involvement of the orexin system. And I think with the new class, dual-acting orexin antagonists, it's definitely something that should be explored. I've also started using it off-label across many types of dementia, but including FTD. There's something about these drugs with their lack of cognitive side effects and balance issues that make them particularly interesting. We don't have good data to say, oh, this is the best treatment given the nature of these diseases and the side effect profiles. So the key thing is to think about sleep disruption when working with these patients because it's a major problem for caretakers. So it needs to be carefully assessed and treated when it causes a lot of functional impairment, and trying to use drug classes that don't have too much side effects in our patients.
Yeah, that's an incredibly important clinical point. I feel like sleep problems, if you don't address those, most other things are going to be really difficult to get better. It's often one of the first things that I focus on when it's present because it can be so disruptive for patients, their distress level, and their caregivers' distress level.
I found that families can deal with a lot of behavioral issues, but if they themselves don't sleep well because the patient wakes them up, that's often what will be the tipping point toward requiring placement in a nursing care facility.
Absolutely. I often use the oxygen mask metaphor. The caregivers have to get their oxygen masks on before they can help somebody else with theirs. And in this case, sleep is just as vital as oxygen for a lot of them. So this study was specifically in genetic forms of FTD. 80% or so of FTD is sporadic. Can this study tell us anything about the sleep problems in that population, or should we be careful in extrapolating from these genetic forms to the sporadic forms of FTD?
So the interest of studying the genetic forms is that we can study them also in the pre-symptomatic period and very early symptomatic period, as opposed to sporadic FTD, where the research cohorts tend to be more advanced patients, because that's when we can confirm with 100% certainty they have the diagnosis. So they're often harder to study in the milder disease forms. There's a lot of overlap between sporadic FTD and genetic FTD. In some prior research work, we showed that the sequence of disease progressions follows similar types of networks, and that's why they can present both with the same phenotype of, let's say, behavioral FTD, even though one is genetic, the other is not. So I think there's sufficient overlap between the forms to conclude that this can be informative for sporadic FTD, although there's probably less of this hypothalamic involvement in the sporadic FTD compared to MAPT, which tends to really localize in medial, temporal, and these subcortical structures.
Have these findings had any impact on your practice when seeing patients with genetic or even sporadic frontotemporal dementia? Or maybe another way to ask this is, what recommendations do you have for, say, a general neurologist in the community who may be looking at their schedule next week, seeing that a patient with FTD is coming in and they're experiencing sleep problems?
The first message for the community neurologists is that we need more genetic testing of these patients. And particularly for treatments, there's a lot of treatments that are being developed targeting genetic FTD, and particularly progranulin mutation, but some C9 as well. And there's a major issue of finding the patients for trials. So my first message would be that if you have FTD patients, ask about family history and try to develop the path toward genetic testing. And there's some registry for research, and there's the Association for FTD organization that is very good that people can be sent to. But for the sleep part, I would say ask the question about sleep biorhythms. Do they wake up often? Do they fall asleep very late? Are they delayed in their sleep cycle? And then depending on what you find, you can adjust your treatment. Sometimes it's just good psychoeducation, changing some behavioral measures like use of screens or coffee or things like this. And when you require treatment, then you can look at what's the pattern. If it's purely a sleep shift, then some melatonin can be tried first. But then if it's more than that, that's where we go into the DORAs we talked about, and then other off-label medication, the low-dose antipsychotics we use, even though we know that there's some risk associated with those treatments in dementia, and then the other drug classes, just being aware of their side effect profiles.
In the few seconds that we have left, could you summarize for me the key take-home message?
The key take-home message is that sleep problems are common in genetic FTD, and that there's a particularly severe form in the MAPT mutation carriers, and that in those patients, it seems that it's disease that causes atrophy in the hypothalamic nucleus involved in sleep regulation that is probably causing the problem.
Thanks so much, Tristin and Simon, for sharing your findings with us, and thanks for taking the time to discuss this important paper.
Thank you.
Thank you.
I've been speaking with Tristin Best and Simon Ducharme, lead author and senior authors on the paper titled association of changes in cerebral and hypothalamic structure with sleep dysfunction in patients with genetic frontotemporal dementia, which I would encourage everyone to read in Neurology.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.